we have our very own Paul Sempera, and we're so excited to have Paul speak. He did a preliminary version of this session to our occupational physicians, and you'll see based on Paul's history how important it is to have him speak to this today, and his passion. Paul's been working in occupational health and safety since 1978, helping develop and implement an occupational health and safety program that included silica and noise assessment and control program at a loud foundry and machine shop back in the day, and then he was at the standards and programs branch of the Ministry of Labor, preparing supporting information for the designated substance regulations for silica, lead, and coke oven emissions. He spent 10 years at the Canadian Centre for Occupational Health and Safety, advising and providing practical information on occupational health and safety to employers and workers, such as chemical hazard summaries, publications, and databases and WMIS training materials. 10 years he was with us at our Hamilton clinic, 15 years at WSIB as an occupational hygienist in the Occupational Disease and Survivor Benefits Program branch. So, and as a scientist in the Oct Disease Policy and Research branch. So you'll see how important that comes into play in the talk that he has for us today. And now we're lucky to have him back with us over the last 3 years as an occupational hygienist working on our larger cluster investigation projects like McIntyre Powder, GE, and Ventra. So please welcome Paul.
Thanks, Kimberly. And just very briefly, I mean, on the topic of regulation development, as Kimberly mentioned, I had the opportunity, way back in the early days when dinosaurs roamed the earth, being involved in sort of the early stages of the designated substance regulations, and that was a very interesting process. And again, very similar, gathering comments and input from industry and labor and that sort of thing, and then trying to sort of devise a regulation. And I don't know if people remember, silica was kind of initially, what we refer to as a compromise regulation. The limit was 0.2, and then if possible, get it down to 0.1. And then eventually it became just the 0.1. So yeah, it's not an easy process. Okay, so today I'm going to be talking about respirable dust exposure in mines and the COPD exposure guidelines. So again, it's not an exposure limit, but often numbers are established as for exposures and policies and that sort of thing. So just briefly, I'm going to do a little bit of a background just to give some context, and then looking at some of the exposure assessment considerations, because really what I did for the physicians was a much longer presentation, and it kind of had both pieces, the exposure assessment and then also the epidemiological basis for the COPD guideline, and that part's going to be presented at a future webinar through OCAL. So I'm going to talk briefly about the historical measurement of dust in mines, and then some of the issues around converting total dust count particles into respirable dust units, the WSIB procedure and the data they use for assessing mining exposures, limitations of that information, and then more recent information. And this is an important thing to keep in mind as we go through this. It was 2001 that the WSIB came out with the COPD Adjudicative Advice Binder. That's what ASMD stands for. And sorry for all the acronyms, but these things get kind of wordy. And then there'll be some conclusions. And as I say, the epidemiological evidence piece will be a separate webinar. So at the present time, there's no policy for the adjudication of COPD claims. It's not like, the policies they have for lung cancer and gold mining and so on. So, but, we constantly see adjudicative decisions and WSIB appeals referring to this WSIB exposure guideline or criteria or threshold, requiring a cumulative respirable dust exposure of 20 to 50 milligrams per cubic meters. And again, as supported by the adjudicative advice information. So and some of you are probably familiar with this, the adjudicative support material binder is essentially two parts. There's the exposure assessment piece and then the scientific review of the study. So some of the occupational groups that are included in that are hard rock miners, which is obviously the focus of this presentation. And then a series of occupations and industries where you would expect to have high dust exposure. And anyway, just moving along. So the support material, I'm just going to refer to that, refers to an average intensity, and this seems to be where this 40 to 50 milligram per cubic meter year comes from, is that of the study groups they looked at in that scientific review, and again, it's now over 20 years out of date, it seems to suggest that they somehow came up with a mean of 2 milligrams per cubic meters, and then an average duration of about 25 years. So, you know, it's not explicitly stated, but this seems to be the basis for it. It's not clear, you know, it kind of says all studies or study groups. It's not really clear which studies they're based on. And as I say, the information is more than 20 years out of date. So just quickly, what's the difference between adjudicative advice and policy? Adjudicative advice is much more comprehensive. Each of those sections, the adjudicative advice and the scientific review, are both about 100 pages long. And any of you that have seen the occupational disease policies online, the actual policies are much briefer. They're a few pages, and they don't have all the supporting information that goes behind them. So they kind of say that it's not to direct the adjudicator, which is kind of contradictory, because, you know, there are very specific steps that they lay out there that adjudicators should follow in assessing the exposures. They're not required to refer to the chapter and to, you know, consider new scientific or technical information. I don't know how individual adjudicators could do this, but they also recommend that, you know, they take the advice of medical and technical staff of the board. Right now, all the medical work is being done externally by external occupational medical consultants on contract. So it's very hard to kind of, you know, consult with them. But there is an occupational hygienist, and he's on the, the list of participants, is available to for some of these claims or appeals. So historically, the measurement of dust, it really kind of breaks down into two periods. Before the late 1970s, and there's sort of a transition period here, total dust particles were collected in, you know, very rudimentary, you know, very primitive instruments like calorimeters. Literally, the particles were collected on a microscope slide and then counted. That was how they did the assessment. But then as more scientific information came along, it was realized that it's the respirable sized particles that are the most important biologically. And it's the weight or the mass of these particles that are more important than the count, than the number of particles. So the earlier epidemiological studies only had particle count data available, and it was the only data available to estimate the exposure of miners. And then as I say, we transitioned into the gravimetric measurements. There's this problem of converting particle counts to milligrams per cubic meter, whether it was for the basis of epidemiological studies or to assess exposures. And as I say, this is a theme that continues into the next webinar. So just very briefly, particle counting, like I said, is very rudimentary. It captures 1 second worth of air. The particles are deposited in the slide and counted. So then they move to size selective gravimetric sampling. Most people in the audience are familiar with this. You got a battery powered pump that can be clipped on a belt, and then you have the filter assembly that can be clipped on a lapel. And so the size selective device means that as the air is drawn into the sampler, there's a cyclone that literally spins the air, and then depending how you set up your cassette and filter media flow rate and so on, you can collect different types of particles. So you can collect inhalable, which is anything that gets into the respiratory system. So roughly 10 microns and less, the thoracic portion that gets deposited anywhere in the lungs, and then the respirable portion, which gets deeper into the lungs, into the alveolar region. So the primary source for the particle count data for Ontario mines is a series that was, and again, some of you are very familiar with that, the semi-annual reports of the Mining Accident Prevention Association of Ontario, MAPAO, that collected this information between 1959 and 1982. They didn't actually go out and do the measurements. The measurements were being done by staff at each mine, usually mining engineer and that sort of thing. And then they were recorded on a standardized form that MAPAO provided, and it was called Summary of Semi-Annual Survey of Air Conditions, not air conditioners. And so then you'll see in a second an example of it. So that information was recorded and submitted to MAPAO. And then what MAPAO did with all that data from all those mines, you can imagine, semi-annually, there's quite a bit of information that's being gathered. They summarized the data, and so that for two main purposes, so that individual mines could compare themselves to other similar mines. So a specific gold mine could then compare themselves to all gold mines combined and see how they were kind of performing, if their exposures were higher or lower. And they also provided summarized data to WSIB for compensation purposes and the Ministry of Labor for compliance and enforcement. So initially, the paper originals of all these dust survey reports were, later years copied onto microfiche. And again, some of you will be familiar with, the old days of getting the microfiche and going to the library and putting it into the microfiche reader and reading it that way. Anyway, so and then MAPAO transitioned into Mines Aggregate Safety and Health Association, or MASHA. And that in turn is now been superseded and is now part of Workplace Safety North. But a continuing problem has been this issue of trying to get, copies of some of these semi-annual reports. Office of the Worker Advisor and worker reps sometimes have been, fairly successful in getting some of these reports for the specific mines that say that a miner worked at. And other times it's been a little bit more difficult. So here's just a quick example of a typical one of these reports. And you can see this, it actually captures quite a lot of information. So it's all the different operations, the number of sites that were sampled, the number of samples at each one, and then the average particle count. So for example, here you've got 11 samples. It averaged out to 394 particles per cubic meter. And then there would be an overall average. And this was typically the number that was captured and then summarized into other reports by MAPAO. But they also had the mines record how many of the samples fell into different ranges. So 0 to 300 ppcc's, 300 to 500, 500 to 800. And those numbers are kind of based on, at the time, MAPAO had a guideline for gold mines of 300 ppcc's. So then, you would know that you had that many samples that were, within or below the guideline. And then the other range is 300 to 500, with 500 being what the WSIB uses as a definition of dusty gold mining for policies like the lung cancer and gold mining policy. But you can see here, so if all you get out of this semi-annual report is that the average was 328 ppcc's, you think, okay, well, that's not too bad. We're pretty close to the guideline of 300. But when you actually break it down and look at the number of samples, in this case, 45% were greater than 300, 20% greater than 500, and 6% like much greater than 800 even, which is kind of considered the upper limit of kilometer measurements. And you can see the overall range here is quite significant. These numbers may seem close together, but you'll see when we talk about converting particle counts to gravimetric results, those are huge differences. So just some quick observations about the MAPAO semi-annual surveys. So the kilometer measurements were initially used, or the purpose was to sort of take some measurements at different areas of the mine to judge the effectiveness of ventilation or other control measures, because over time, things like, water sprays and other techniques of reducing dust were being introduced. It wasn't necessarily intended to be used as to assess personal exposure, but the thing is, that's the only data we have up until the mid to late 70s. So, we're kind of stuck with it. Yes, it's not truly representative, but it's the only exposure data we have. But the main limitation of the MAPAO summarized results is this averages of averages. So, in other words, they would take these semi-annual reports, average them out for that mine, then in turn average it out for all that set of mines. And so by the time you kind of got you average it down, you lose all that detail of the range and the extent of the exposure, or the specific operations where you've got some of the high exposures. And a good example of this, and again, some of us are old enough to remember when the Ham Commission, James Ham was chairing this Royal Commission on Health and Safety of Workers, came out in 1976. One of the sections in there talked about dust exposure in mines. And what they had in there, and this is an often duplicated and repeated table, is that the MAPAO provided a report that summarized the data between 58 and 75, and then came up with this kind of table showing that in the first half of 1960 and the first half of 1975, how the dust counts dropped. And again, you've averaged all those numbers together, and so then when you compare it to the various guidelines, 500 ppcc's for nickel, 300 for gold, 200 for uranium, these numbers aren't too bad. And you can kind of say to yourself, hey, we're in pretty good shape. The dust exposures have really gone down. And then one of the other things, this Royal Commission report was one of the key motivators for the development of the Occupational Health and Safety Act. And so in 1978, and we all know about the Green Book as it's called now, that's when the act came into effect, and then all the other regulations. And you heard Breyer talk about, the more recent regulations. So, ever since then, there's always been amendments and additions and whatever. So from that table, and this is again an often reproduced graph. If you look at the 1960 to 1975, and for the different mines, you see, yeah, overall we got a nice reduction here. So this issue of converting particle counts into gravimetric measurements, the adjudicative support material binder provides information and outlines how to convert, or how they came up with a method of converting these counts into gravimetric values. So in other words, you need to do that so that you can come up with this figure of so many milligrams per cubic meter years. So, and again, any of us in the field will know Dave Verma. Fortunately, he passed away just a few months ago. He was a major figure in occupational hygiene in Ontario, and one of the key papers that he produced in 1989 was where he correlated. They did side-by-side sampling of kilometer measurements and gravimetric measurements, and that's the best way of doing making that comparison, and then coming up with some sort of conversion figure or equation, rather than depending on some mathematical theoretical approach. So what they found is that this relationship between the dust count and the gravimetric amount was nonlinear. So it wasn't, and you'll see in a second why this is important. It's also important to realize that this table was done specifically for their study on silicosis. So it only had correlation values between total dust and respirable dust. And that's just the paper. And these are all links. And yeah, these presentations will all be available, so you can look at these papers at your leisure. So just very quickly, this was the table that they came up with. So they had measured all the gravimetric from 0 to 5 milligram per cubic meter. And then these are the equivalent ppcc counts. And this is the equation, those of you like math, that they use to come up with these figures. But, and again, this is one of the key things to remember. Like a small increase, again, going from 489 to 507 doesn't sound like a lot, but it's actually, you got a 50% increase in the amount of respirable silica. So that's a key thing to remember. So in this case, you know, for gold mines, a 4% increase it resulted in a 50% increase, you know, going from 2 to 3 milligram per cubic meters for silica, and for uranium mines about a 14% increase. So not much of a increase in the particle counts, has a significant increase in respirable silica. So WSIB had that paper, they had that information from Verma's conversion table. And so they said, well, okay, how can we come up with respirable dust figures? Well, so using Dave Verma's published and unpublished results, he kind of came up, or sort of suggested, that reasonable estimates for respirable dust in the different mines was 5%, 10%, and 20% respectively. So in other words, once you know that 5, 10, or 20% of the dust is silica, you can calculate, you can back calculate, you know, what that equates to as far as respirable dust. So, so this is how it pans out. Is that for nickel mines, you know, 0.1 of respirable silica is equivalent to about 2 milligram per cubic meters of respirable dust. Gold mines is 1, uranium mines is 0.5, and so then they, and this is Verma's original table here, and then based on the amount of silica contained in the dust in the different mines, they came up with this table, which is again a very much used table, because now you can kind of, you know, go back and forth. You know, if you know that the silica, you know, was 0.04 and it was a gold mine, this would be the equivalent ppcc. Not so important, but the important thing is the respirable dust, because then you can calculate you know, the cumulative dust exposures and so on. So also there was they have a whole series of tables, and it gets, I mean, even for me, confusing to sort of follow in some cases. So there's a series of tables in the adjudicative advice material that summarized information from a series of sources. And well, two things to consider. First of all, I mean, it's only, you know, a lot of this is from early years, but the main thing is that these are all average dust counts for selected job categories. And then this is how they came up with, you know, with trying to simplify all this information into sort of some usable numbers, you know, for the adjudicators. So again, here we go again with this averaging of averaging. So the mean exposure level for the different jobs from what they call different mining camps, like geographic areas as opposed to individual mines, were combined. And this will make a little more sense in a couple of slides. And then they took the jobs with similar exposure levels and grouped them together into high, medium, low. So here's an example for gold mines, because then they have a series of tables like this for gold mines, uranium mines, and nickel mines. So And again, here, a couple of slides ago, I showed you the sources for some of the data. So this is personal communication from Mueller. He was one of the chief physicians at the Ministry of Labor at the time. So he provided these numbers, these estimates. And again, this is before 1960 and after 1960, the kind of this belief that there was this major reduction in dust levels. Magically at 1960, all of a sudden the dust levels were half or less. And then some selected, you can see here, it's only a range of 3 years from 5 specific mines that they use their semi-annual reports. So then they took all these numbers. One thing before I move on, just because I'll come back to this again later on in the presentation. If you look at the numbers for surface operations, which generally are thought to be much less exposure to dust than underground, but if you look at these numbers, they're just as high, if not higher, than the underground operations. So just something to keep in mind. So they took all these numbers from these tables and continued to summarize them. So then, I know it's a little bit hard to follow, but all those numbers in those previous tables were then squished together into pre-1960, post-1960. So then you had, MAPAO and the Mueller data for the different jobs. And then it was summarized even further, where they grouped together certain occupations or jobs into high, low, and medium exposures. And they describe the high exposures as being greater than 2 milligram per cubic meter years of respirable dust, medium 1 to 2, and low less than 1. So some of the limitations of the WSIB exposure data is that, these dust tables are oversimplified generalizations, as we saw. And, again, this idea of, this pre and post 1960, and again, it repeats here, but this conversion from particle counts to milligrams per cubic meter is, a very, very critical piece. And so, for example, here for gold mines, if somebody worked for 10 years at 489 ppcc's, let's say that was his average exposure, which is equivalent to 2 milligram per cubic meters. It worked there for 10 years. That would be a cumulative exposure of 20 milligram per cubic meter years. And so he wouldn't qualify or wouldn't be accepted if he had a claim for COPD. However, if there's this small increase, as we saw earlier, of just up to 523 or equivalent to 4 milligram per cubic meter years, now all of a sudden 10 years, it gives you 40 milligram per cubic meter years, and he would meet the criteria for COPD. So, and again, this exposure data and all the information is more than 20 years out of date. It doesn't include some analysis that Dave Verma did and others in 2014 and 15 on the earlier 1978 gold mining survey done by the Ministry of Labor and the 1974 Ministry of Health survey of uranium mines, because until those papers were published, that information wasn't really readily available. And then I'll talk also briefly about the more recent development of the Ontario Mining Exposure Database. So, as I say, there is these papers that came out that sort of analyze in a little more detail the Ministry of Labor survey that was done in gold mines, and then the Ministry of Health survey that were done in uranium mines. And again, I've included links to all these articles. So the 2014 paper for the 8 gold mines, so the mean respirable dust exposure was, you can call that 1 milligram per cubic meter year. 1 milligram per cubic meter, and respirable quartz or respirable silica was 0.08. But what again is sometimes lost when there's all this focus on means is look at these maximums. I mean, this is like almost 6 times higher and the silica almost 10 times, well, more than 10 times higher. So again, these numbers were at or below the exposure limits of the time, but you know, if the new limit is adopted, then most of these operations and occupations would come nowhere near the proposed ACGIH TLV. And this survey data wasn't included in the WSIB information. So then Verma et al. Also looked at the Ministry of Health survey of 2 uranium mines, Rio, Algoma, and Denison. And what was happening in this period, as I said earlier, there was this transition from particle counts to gravimetric assessment. And so they were tinkering with using different types of samplers and different types of sampling methods to try and figure out what's the most practical, useful system to measure dust in mines. So they used a variety of impingers, kinemeters, and gravimetric dust samplers, and the paper provided averages and ranges of respirable dust and respirable silica from these different methods, and in a number of operations at each mine. So the tables also provided the percentage of samples that were found to exceed the respective OELs. So we'll see that in a second. So I kind of the paper has for each operation. They included the percentage of samples that were above the respective OEL. And what I mean by that is that depending on the method, the relevant OEL, is related to that method. So, 5 million particles per cubic foot, ppcc's, and then for milligrams per cubic meter. But the important point here is that so many of the samples exceeded, what should have been the OEL. So, and Verma et al., had this specifically in their 2015 paper about how this data would be useful for epidemiological studies and also for compensation claims. So this brings us to the Ontario Mining Exposure Database, OMID. This is a recent database that contains the air sampling data from several sources, MAPAO, and we saw what those look like, from 59 to 75, gravimetric data from the MOL, roughly from the 70s to early 90s, and from individual mining companies. And OCRC, and Victoria certainly knows about that, consolidated the data. There was literally boxes of paper records from all these different sources that had to be put into a spreadsheet or some sort of electronic version that could be used and analyzed. So right now it contains about almost 120,000 sampling records for 140 hazards that were collected over a broad period of time. And although there's some of the earlier data from the 50s, most of it is from 1970 to 81. More than half the records are for respirable dust, silica, and radon. There's over 4,200 respirable silica measurements from gold, uranium, and nickel mines. And then there's a whole variety of other things. So, OCRC shared the earlier stage of OMID with OCAL, here again with all these acronyms, to make it searchable in a variety of criteria, and you'll see what I mean in a second. And I have to put a big shout out to Martin Albinger, who's another hygienist at OCAL, who's done a ton of work on OMID to make it useful and searchable and so on. So this is just a screenshot. If I had time, I could have done more of a live kind of demonstration of it. So I know it looks very busy and very cluttered, but The important thing is that, so now we have this database that you can search by the type of hazard, by the year, underground surface, personal area, you know, type of ore, gold, uranium, whatever. These have all drop down boxes. And then within that, you can look at specific jobs or locations, years. So if it, you know, if it's like 0.75, so that means that that would be a 1968 MAPAO report from the last quarter of the year, and 0.25 would be the first quarter of the year. Anyway, and then Martin has also built in a conversion calculator, because you'll see here, and just in the screenshot, you're going to get a mix of particle counts and milligram per cubic meters. So you need to convert, you know, one or the other. So if you're interested in particle counts, you got to convert from milligram and vice versa. So there's a nice conversion in here. There's also some statistical analysis that's available. You know, down in this corner, you can calculate things like median, standard deviation, and that sort of thing to, again, kind of give you a little bit more information about the data that you're interested in. You can also export it to external analysis like IHStat.
Oh, sorry, Paul, it's
Yeah,
Kimberly. I want to make sure I leave room for questions. I know it's like, I just don't want you to get too hung up. You're
yeah,
close.
yeah.
Okay.
I'm almost done. I'm
Okay.
almost done. So RCRC, OCRC published a paper just a few months ago on where they analyzed the respirable silica measurements from 71 to 91, and found that the arithmetic mean for gold mines was 0.1, which is, again, very similar, and you saw that earlier, to what Verma found from his analysis of the gold mining survey that was done by the Ministry of Labor. And another observation they made is that, yes, although there was a decrease over the years underground and surface operations, the probability of overexposure to respirable silica remained high in the Ontario mining industry. So again, this idea that, you know, after 1960, you know, all the exposures were much lower isn't really borne out. And this ties in. Remember, I mentioned earlier about the surface and underground. So they observed from their analysis that there was no difference between surface miners compared to underground, and some of the highest measurements were actually on surface operations such as crushing and refining. So here again is a link to the paper. So OMID is turning out to be a very useful tool to estimate an individual miner's exposure to respirable dust and silica. It provides much more information that's available from the adjudicative support material for the COPD. And by using detailed work histories, you can search by mine, as I've already said, task, time period. You can slice it and dice it, you know, so many different ways. And of course, OMID isn't perfect. There are gaps, you know, the data isn't available for all mines, jobs, tasks, and periods, and that sort of thing. And so, you know, if there are gaps, then you can kind of take a step back and say, okay, I don't have information for this particular gold mine, but I'll look at, you know, all gold mines for the same job title and task, and then you can make some inferences about what the exposure might have been. So we've been using OMID now to do individual exposure assessments, and we recently used OMID to estimate historical silica exposures for a case series report on sarcoidosis among Ontario hard rock miners, and that's been submitted for publication. So, in conclusions, as I pointed out earlier, there's significant limitations in using the exposure data that's available in the 2001 support material for COPD. We already talked about some of these limitations. OMID provides a new tool for a much more accurate assessment and meaningful interpretation of exposures. And in my opinion, you know, I think it should be used routinely in the adjudication of COPD and other occupational disease claims. And I think this is also an opportunity for collaboration between OCRC, OCAL, and WSIB to continue the development and improvement of OMID. I mean, why not have something that, we can all use, and it's not like, somebody's got one set of data that's different from somebody else's data, and, you got this sort of, let's have a common thing that we can use. So my final comment is that this emphasis of using cumulative exposure to respirable dust as the main or only occupational risk factor for COPD is inaccurate and misplaced, not only from the exposure side, but you'll see in the follow-up webinar from, when we look at some of the occupational studies, epidemiological studies that were used in to support the guideline. A lot of it was, for the mining anyway, it was based on South African gold mining studies, and there's some limitations with that. And there's been, obviously, since 2001, there's been a considerable amount of literature on COPD and, respirable dust, respirable silica, and individual aspects of COPD, rather than, having it all lumped together. McIntyre aluminum powder, without getting into too much detail, also plays a role, because that was some additional respirable dust that miners were exposed to. Diesel exhaust, and then this whole category of vapors, gases, dusts, and fumes. Thanks very much, and I guess I'll turn it over to Kimberly.
Thanks, Paul. That's awesome. And I honestly, it blows me away who we work with every day and their expertise in this multidisciplinary team. And I know Dr. Christine Oliver's online, and we wanted to have her speak with Paul today, but we're going to, as Paul alluded to, have Paul and Christine, Dr. Oliver, follow up on the medical side of all of this. And she asked the very pertinent question. And I mean, I just want to continue. I mean, who else but Paul and a lot of our hygienists and occupational health nurses and physicians and client service coordinators, just this interdisciplinary team that's working on, as Victoria pointed out, it's a loop. Primary and Breyer at the beginning, there's regulatory change. And then Victoria talking about occupational exposure limits, and there's primary prevention, secondary prevention, and tertiary prevention, but it's all a loop. I mean, we use what we're doing, helping out with tertiary prevention to impact primary prevention. And that's, very powerful stuff. But anyways, Alec also provides kudos, but Dr. Oliver asks, do we have any idea why there is no WSIB COPD policy, as for example, there is for lung cancer? And I know it might be a rhetorical question, Paul, but you do have a lot of experience.
Yeah. Well, just very recently, WSIB announced that they're going to be establishing a scientific advisory table on occupational disease, which is essentially a resurrection of what was previously the Occupational Disease Standards Panel, which was also became Industrial Disease Standards Panel. And again, some of us will remember, they would take on, things like mining or machining fluids, and they were essentially an advisory table. It's just by a different name, and there would be representation from sort of the scientific side, labor, industry, and to kind of put something together as far as recommending what to do about a certain, like to establish a policy or to revise a policy and so on. And I remember going to some of those meetings on machining fluids, and you had people there from GM and Ford. You had Kathy Walker from CAW, and you had the people that did the scientific reviews. So hopefully this new revised WSIB scientific advisory table will take on COPD. I think that, and certainly there's a series of other policies that are hopelessly out of date that really need to be looked at.
Thanks, Paul. And I'll invite all the speakers to turn on your video, and for others to ask questions to our whole panel, should you like, with this last few minutes. And I will say, although sometimes these threads just exist in my head, that this one around Lung Month is particularly, well, they all they all thread together in my head in terms of this, as we mentioned, primary, secondary, and tertiary prevention, and you know, the regulatory changes that Breyer introduced, and Victoria talking about exposure limits and how those regulatory changes may happen, and then Paul talking about, you know, looking at policy change. So it's all about change, and we all need to be involved in that change, as Victoria pled to us and Breyer. So, you know, write in to those consultations and give us the reality out there in the workforce, from the workers' perspective, from the, you know, from the industry, from labor. We want to hear from you. I think that was a common message through all of the presentations. You're getting, people are quiet in the chat. I don't see, thanks Alec for the very kind comment about learning after all these years from our professionals. I don't see any other questions. Jen, do you or Tony on Facebook Live?
There's one from Kevin. He says there will be a lot of past assessments based on this empirical approach. Do you think that these will be looked at retrospectively?
Thank you.
I'm not quite sure I completely understand the question. So
I can just chime in if you like, Paul.
Yeah.
You know, you look at all the past assessments based on the 2 milligrams per cubic meter cumulative years, you know, 40 to 50 milligrams per cubic meter over a kind of working lifetime. Like, this is really important information, and I'm thinking that there'll be a lot of old assessments that have been based on this kind of rubbery approach. You know, it's been a dog's breakfast. You know, it's kind of merging all the different minds together.
So
yeah.
Sorry,
So
I'm not sure exactly how that would happen, but you know, more recently, and I think most people are aware that WSIB had an external group look at the issue of the role of smoking and COPD, because in the past, and it's right in the adjudicative advice information, there would be an adjustment for smoking. So if somebody had a 20-pack year smoking history, and then whatever milligram per cubic meter year of dust exposure, there would be an offset, or they would, you know, they wouldn't get the full benefits. They would make that adjustment because COPD was playing a role. Cigarette smoking was playing a role in the COPD. But this external review, you know, came up with the conclusion that you can't really differentiate between COPD caused by smoking and COPD caused by respirable dust, and there really shouldn't be this adjustment. So WSIB released a statement, and they're actually now going back and reviewing all those COPD claims that had that adjustment in there for the smoking. So it's not impossible, but yeah, I don't know. I don't know how they would handle it, and if somebody's on here from WSIB, maybe they can chime in.
I have a question for you on that, Paul. Is it that they're going back to claims they've compensated to assess the level, or whether they're going back to claims that were never accepted?
Well, they're going back to the accepted claims where they took in the adjustment for the smoking.
Okay.
So, you know, if somebody ended up getting only half or you know, 20% or 80% of what they're entitled to, they'll now get the difference. And from going forward, they're not going to make this this adjustment for smoking. And if you look at their website, they just released a kind of a statement summarizing all this. I can't do it right now, but I can provide a link later on to it.
Sure, and I think Christine, feel free to unmute, and we will lose some people, folks, as we hit the 3 o'clock mark. But for those of you willing to stay a couple more minutes, we're happy to take a couple of questions. So Christine, do chime in, but she's mentioning that epidemiological data indicate at least an additive and probably a synergistic interaction between smoking and for risk of COPD as a result of both exposures. Oh, sorry, yeah, you have another acronym in there that I don't have in my repertoire. So yeah, Christine, and we want Christine, Paul and Christine, we're going to do a duo here, but we wanted to be diverse and not all OCal. So we'll have a winter webinar series later, usually in and around February, around World Cancer Day. So stay tuned for that. Any other questions for our panel? Well, I do want to say the collaborative impact is evident in the occupational health and safety system, and Paul pointed out a couple of other opportunities. We continue to identify those with the ministry, with our research partners, with all of our work at all the health and safety associations, and there's hope that this data and evidence driven strategy around occupational illness, and our new CPO, who has background both as medicine and medical background and epidemiology, may help bring this stronger and stronger collection of data, centralization of data, sharing without barrier to prevent people from getting sick. So I just I will end on that and thank all of our panel, Victoria Arundale, Briar Musson, Paul Sampera, and hope you join us for the next 3 weeks. Check out our links, and thank you for being here, and have a wonderful afternoon.